Hey guys, my name is Dr. Mursi. Welcome to my channel. It's been a minute since I put anything on see? You're good. Hey guys, my name is Dr. Mursi. Welcome back to my channel. If you're new here, welcome to my channel. It's been a minute since I posted. I have been more active on my Instagram account. I've been making a lot of reels, so go ahead and check that out and follow me on there. You can go to mursi.md. And I think the last time I posted, I had said that I'm returning, but this time I think I'm going to be returning. I'm really excited for the upcoming videos that I'm going to be filming and putting out there because I think it's going to be fun. Without further ado, let me introduce you to my special guest who was my senior and kicked my ass, but I learned a lot from her and we have become really good friends. She's someone I admire and look up to. She's really sweet, humble, down to earth, and a very caring person. She's currently a fellow in palliative care, which is what this topic is about. Here is Dr. Elsa Montoya.
Hi.
Hello. Tell us more about yourself.
Hi, I'm Elsa Montoya. I'm originally from Mexico and I came here to do my family medicine residency. I moved here with my husband, who is also a physician. He's an OBGYN practicing physician now. So yay, I'm excited to be here.
I actually thought you were Italian.
Oh.
Yeah, I told you that.
Yeah,
I thought you were Italian for the longest time.
Yeah, I think Italians will be very upset about that.
What?
The accent is so different.
Okay. Alright, so the topic of this video is about palliative care, and I wanted to kind of have a discussion about it. What better person than you? Tell us, what is palliative care? Because I feel like a lot of people don't know what it is.
Yeah, super important. I didn't know where it was when I originally came to do my residency. So palliative care is an interdisciplinary specialty where the goal is to treat and prevent patients' suffering, improve quality of life, achieve by treating all the symptoms, and at the same time this has to be a patient who has a life-threatening illness or a terminal condition.
So essentially with palliative care, this is someone that helps people towards their end of life. Is that what it is alone, or?
So that is somehow a common misconception, I would say. In general, you can treat a patient who has, a severe condition. They might not die of it. For example, patients with severe sepsis, patients in the ICU, they consult us a lot for patients who might be young, but they have very severe diseases, and sometimes we need to either treat symptoms or talk to the families regarding,
like what their options are and whether they want to keep going. I feel like palliative care, especially inpatient, they're almost like the voice of the family and the patient.
Part of why I came into palliative care is because my background is family medicine. I love family medicine. Yes. But in general, for me, the time was so important. So in palliative care, we do have a lot of time with our families. Yeah. We discuss a lot with them, and we get to know everybody. In general, inpatient, outpatient, we spend a lot of time with our families, trying to understand what is important for them, what does quality life means for them, and that's why I believe we're one of the biggest advocates for patients in the hospital.
That's awesome, which brings me to my next question. Can you tell me about inpatient versus outpatient?
Yeah, that's a very loaded question.
I know.
But yeah, so let's break it down to inpatient first.
Yes.
So when can you consult palliative care in inpatient? So patient has cancer, we are already treating physicians as outpatient, we're managing symptoms. They come with untractable pain, nausea, anything that is untractable symptom, we are absolutely consulted in those cases. We can treat the pain, and I know most of the people is not comfortable dealing with very high doses of pain medication, so that is when we come and we definitely can help you. Family meetings, I feel like it's a big chunk of what we do in the hospital as well. And in general, we really want the primary team to have those first conversations with the patients, that they understand what is going on, and the families are involved as possible. If there's a moment when you're hitting a moment where you're like, you know what, there's like discordance within the family. There's someone who says something, and you know, I feel like they are not really grasping the severity of the situation. We can absolutely come and assist you with difficult conversation.
Let's give an example, like with COVID, because that is something that's really relevant, and I feel like a lot of patients are, I mean, the hospital is saturated with a lot of non-vaccinated COVID patients who are in their deathbed, and a lot of times the palliative team comes in and they have to have the really hard, tough conversation. So give us like from the top to the until like you're kind of out of the picture.
Yeah, so in general, patients in the ICU, the teams are really amazing in the setting that they are very good at communicating everything with the families and the patients if they are able to respond, of course. They consult us again when, for example, 80% of the population who is in the ICU with COVID, mostly unvaccinated people. So those conversations are very difficult because sometimes people want treatments that are not available in the system, is not what is recommended, is not on the treatment plan. So sometimes people expect you to give certain medications, but they don't really want to go through intubation or like be very aggressive with other things. So there's moments where you are stuck in this moment where like, okay, like we cannot move forward to do everything we need to do, and we're stuck with high flow nasal cannula, and the patients are declining, and at the same time, like either we cannot go comfort care, but we cannot be more aggressive. So those are the very difficult conversations that
like you become at a point where now like you've tried everything and they're still not getting better, and so now you have to have the conversation of how much are you willing to do, how much do you want to keep going at this, and keeping the patient, like, because at some point they need nutrition, so there are other things that need to be done, including like placing a peg and all that. So then you guys come in to discuss like here are the options, like kind of give them, you know, the realistic point of view, and also advocate for them if like they want more.
Patients, for example, who have advanced dementia, they're not eating, they don't feel like they want to eat, but family is very concerned about nutrition, they're not eating, what do we do? And again, is this question of like, is putting a NG tube and, you know, potentially a PEG tube in the future versus doing comfort care, is a lot of the conversations that we can have. And again, in certain patients, advanced dementia, is it really worth to do a PEG tube when it doesn't decrease the risk of aspiration, when it doesn't improve the quality of life? Those are the conversations that we really need to do, and it's most of the time not only one conversation.
In the ICU, you're kind of like, all right, you know, this is what it is, this is kind of what's going on, this is what's happening. And we were in a family meeting, and the PA was like just kind of slowing things down, making sure that the family understood what was happening and not kind of quickly rushing by like what, like especially the intensity of what was happening, and pausing the attending, the ICU attending. And it was such a great experience because I'm like, wow, like I really appreciated her in that moment, and I really appreciated the specialty as a whole in that moment. This attending, like the ICU attending, is badass, right? And like absolutely. He was just like talking about everything, and but then she was like, hold up. Like, because she was the advocate for the family, and I loved it. And I think my respect for just that whole situation, just especially her, like went up even more. And I think that's why I wanted to make this video, to kind of share that, especially because not every hospital has that team to offer. And the other thing that I want to say is I love the fact that you're in palliative care, because I think we really need people like that. I would not be able to do it. I feel like it takes a lot to be able to do that. What made you decide in doing it?
Well, I think first of all, coming from Mexico, I didn't know much about palliative care. I thought it was gonna be so depressing when I first knew I was gonna go into that rotation. But then I feel like if you're going to a palliative care office and you're rotating through there, you will see that how everybody's so happy, chirpy, and in such a good mood.
Yeah, actually I did notice that. I did my rotation.
Yeah.
Everybody's so nice
and I think, yeah, so we deal with very difficult cases,
Yeah.
but at the same time, I do believe that we are the biggest advocates for our
Yeah.
patients, in the sense that we do take our time. We have an amazing team. We have social workers, we have pastoral care, we have nurses aides in, you know,
Yeah.
I guess, again, in palliative care, we have that interdisciplinary advantage, in which we have all the time. We have, you know, that mindset of getting to know our patient and
Yeah.
working with their wishes and their, you know,
What
idea
they
of
want,
quality
yeah.
of life.
Yeah.
Yeah. So, and I love that about it. And it's sad, but at the same time, I feel like I've gotten a lot of happy, positive feedback from our patients and families.
I'll have to say they offered palliative care for my mom, and I knew what it was, and it just broke my heart, and I was like, no, we're not there yet. So I get it, like, personally, even when you acknowledge what it's about, like, but you just, like, you know, so it is triggering for families to say, oh, palliative is going to be involved, because now you're like, wait, what? Like, and now, like, your world shatters, because now you know what is coming down, or how serious it is.
And again, I feel like a common mistake is kind of like putting palliative care and hospice in the same group.
I know.
Where it's like, we as palliative care sometimes follow our patients in the office for years. Some of those patients graduate and they're like, you know what, your cancer is in remission. You don't need me anymore. You know, like, you're not even using any medication. So, like, you go on the work.
Yeah,
so
I love that. Okay.
it's really like, again, I feel like palliative care can be there with you along, you know, the road with you, the family. And I feel like it's just mainly palliative care. If they are suggesting that in the hospital, it's mainly probably family, you know, or goals of care conversations.
Yeah.
But, you know,
an
sometimes
outpatient.
as an outpatient, they can certainly be super helpful, especially if, like, with symptoms or social work, making sure that you have, you know, everything. Yeah.
And I feel like with palliative, it's not just focused on the patient, it's also focused a lot on the family and how the family is doing and coping with it, because they're the ones who are taking care of the patient. So it's important in that aspect, and you guys are also covering that.
Yeah.
Well, thank you for telling us about palliative care. I hope that was informative. I think a lot of people don't know about it, so hopefully that gives some of you guys some idea of what palliative care is. And if your hospital doesn't have it, I think you should encourage the hospital to have a palliative team, as it is very, very beneficial. My camera totally died. I hope you guys enjoyed this video. Go ahead and hit that thumbs up and the subscribe button if you haven't done so already, and the bell button, so that way you're notified every time I post. And go ahead and follow Elsa Montoya, Dr. Elsa Montoya, on her Instagram account. You can check her out here. She's amazing. I absolutely love her, and I am in her home. She has her beautiful tree up. Thank you guys once again. I'll see you in my next video.